now to Dr. Sean Wharton.
Thank you very much. And everyone can see the slides?
Yes.
Great. Terrific. It's so exciting to follow such great speakers, Denise Campbell-Shear, Sarah Kirk, doing a terrific job of outlining how the guidelines started, what the emphasis was, what the components were, and Sarah giving us the information on the bias chapter. It's really important here that we understand that we made the bias chapter the first chapter in the guidelines, and the Indigenous chapter, the racialized chapter, the final chapter. They bookend this entire guidelines. So you can see right away, you see how the guidelines differ from previous guidelines or other guidelines that are really out there. So really trying to address the issue that we have with our own biases, that patients feel, and how racialized groups have challenges accessing care. Then in the middle is all the information about what we can actually do, but those two things bookend. And that's what my talk is about, is applying the evidence and compassion to obesity management and how the Canadian Practice Guidelines actually ends up doing this. So the objectives to discuss that bias can be driven by a lack of the knowledge of actual science. And I will talk about the science of obesity and how that can get rid of bias. And then we'll talk about applying the evidence and compassion and how they applied to the obesity guidelines. My disclosures are here. Here are my research grants and the honorariums from companies that are involved in weight management, obesity management, trying to change the focus, trying to change the dialogue, are companies that I end up working with. We did not receive any funds for this talk here today and for the entire guideline. So 3.5 years of a lot of painstaking work, but it was all worth it. As you know, this has been sponsored. Funds have gone to ASO to help put on this. So let's take a look at the rationale for the new clinical practice guidelines. So Denise Campbell-Shear spoke about this, and I'm going to talk about it in a little different manner, in the sense that one of the main rationales was to try and address our own biases. So we were told by people living with obesity that we were biased. If you look on the right-hand side of that picture in the blue sweater, that is Dr. Ian Patent. He is a PhD in kinesiology, and he led the patient group that gave us advice on these guidelines, the setup, how we should look at it. And that group told us that we were biased. The people who are practicing in obesity management, who are starting to write these guidelines, and we ourselves have to address our own concerns and our own biases to be able to write an appropriate guidelines, instead of going down the same path we would for a hypertension guideline, a heart failure guideline. Let's look at our biases to people living with obesity and how we can make the guideline appropriate that speaks to patients living with obesity. So Ian himself has had bariatric surgery, takes medications, and also works with the psychological interventions. All of those methods and the ability to work with us on helping us to deal with our own biases. And let's go into an example of how prevalent this is. So we know that the most amount of bias oftentimes comes from doctors. So not your partner living with you or the bus driver, but the physicians who are supposed to be helping patients oftentimes have the most bias. We're looking into why that is, but it's interesting. So soon after the guidelines ended up coming out in Canada, this was written in the Canadian Medical Post. This physician feels that she's trying to help, but of course she demonstrates gross bias. So here she states losing weight is too hard because the general attitude of patients coming into my clinic in 2020 is that of non-accountability, not that they have a genetic predisposition that codes for neuroreceptors within the brain that causes obesity to be a major challenge. No. It's non-accountability. That is her opinion of it. And also stating that I inquire about their diet and they're incensed when I tell them that pierogies are not a good choice. Again, blaming and stigmatizing these patients, and discrimination. This is discrimination here. paint billboards with simple common sense info. So it feels like this doctor missed medical school and is not applying evidence or biological processes, and yet is using an opinion. And opinions can come from multiple places. Maybe it came from this magazine, I don't know. But the way that I look at bias oftentimes is that a person uses an opinion instead of using evidence and biological processes and understanding. When it comes to biases within the health field, it is a lack of using proper evidence and proper biological processes. Now, let's go into how we can deal with those biases, because many of us, as I said, even on this line, have biases, and we may not be able to get rid of them totally, but we certainly can work on dealing with them. So one of the first things that we did to try to deal with our own biases is the fact that we used size when we used the BMI and size when we talked about elevated weight. And really obesity and the BMI category was developed in the 1920s, really looking, when it became bigger, looking at insurance tables, and they primarily used young white males to determine BMI status. So if you're an African-American woman with a BMI of 32 and perfectly healthy, do not have diabetes, prediabetes, a strong family history of healthy components and no medical conditions, and you're calling that person somebody living with obesity or has obesity, and you wouldn't call, let's say, a South Asian woman with a BMI of 27 who has most of her family at a lower BMI and has a history of diabetes. She herself has diabetes and she's at that BMI. That would be a challenge. So let's talk about the real factors as medical doctors. What we really have evidence for is impairment in health. If your A1C is 7.2, you have diabetes, and we should work on that. So if your excess adipose tissue is causing an impairment in health, then that's what we should actually look at. And by doing this, we got to a level of compassion and empathy, because now we're focusing on the patient in a very patient-centric way and not just focusing on size. So that was one way to deal with our own biases. The next, and a very important way, is understanding that the science of obesity is very important. So it's all, we know that the organ that deals with obesity is the brain. So even when we talk about gut microbiomes and other things in the peripheral area, they all send messages to the brain, and that then generates sensations of hunger or not feeling full enough, or cravings or overeating. So this is a direct, or even exercise, a decrease in the activity, burning of certain energy. So we know that brain neurochemistry that is coded by genes and then in an environment that causes this elevated weight is our major challenge. And so talking about the neuropathology is important, because this is one of the ways that's been shown in studies to get rid of bias, is to teach people about the actual evidence in whichever field. And in this field, it is the biological health field. So we know that the part of the brain that codes for a lot of elevated weight is the hypothalamus. The hypothalamus is a homeostatic, homeo meaning body and static. So if a person starts at 150 kilos and goes down 25 kilos, that's not stasis. They want to get back to that 150 kilo rates stage, so that they have a static component. So all of the neurochemicals and hormones within the body try to generate elevated weight. And what I mean by that is, if we see here ghrelin, which is the main hormone here that causes an increase within hunger. All the rest of them below actually make you feel full. But what I mean by that they push for elevated weight is that every time you decrease your calories, of course, the bad hormones go up, quote unquote, the hunger hormones go up, and the satiating hormones go down. So there's always the hormones are always in a direction to increase weight when we try to get out of that homeostatic range and do something different, bringing the weight down. So if we can have better control of these hormones, we would do better. But remember, it's genes that code for how much of these hormones you have or what your sensitivity to it is. The mesolimbic system, or the hedonistic system, first part of the brain that came as a evolutionary species for our survival. We needed it to do two things really well. We needed to reproduce, and we needed to have hunger and eat. So therefore, God, whoever she is, was not going to leave this important aspect to simple neurochemicals. It was going to be intense ones: dopamine, opioid, and the cannabinoid system. And what we have to remember is that these genes, this part of the brain is working always. It always works. So there's no time that it is quiet. It's only the only times it's quiet is when it is quieted down by other parts of the brain. So what we know is that surgery and medications can dampen these specific areas, and the other thing that can dampen it is the frontal lobe. So the executive lobe can send messages over to the mesolimbic and hypothalamic area to say quiet things down. If you have the unfortunate aspect of having genetic coding that doesn't send the message over properly, that ends up being a challenge. Of course, we know the executive lobe has a exhaustive type of component. It works really well when it's been rested, when it's not stressed. Till 10 o'clock in the morning, it's working really well. By the time 10 o'clock in the evening comes around, and emotional stressors and the full day of work has been there, that's when overeating happens. And so we know that this is the interaction here. And that's why strengthening the cognitive lobe with cognitive behavioral therapy is a definite aspect in terms of treatment options. So this is what we previously used to do. We used to do the stepwise approach. We used to think of diet and exercise, medical nutrition therapy, and physical activity, and then step up to pharmacotherapy and step up back to surgery. What that didn't do is recognize that what people have a challenge with is keeping that dietary component, keeping the motivation to have the physical activity. So now we changed things around, and we said that the foundations of therapy are medical nutrition therapy and physical activity, but the ability to sustain them are done by three main pillars: the psychological intervention pillar, pharmacotherapy, and the bariatric surgery. Now let's look at those in a little more detail. So here's a more detailed look at it. And in a second, we'll talk about medical nutrition therapy, because this is one of the areas where we were acting in a biased manner as researchers and clinical doing clinical work in the field, and it's changed. Physical activity is an important foundation here, and then we have the psychological interventions. I'll talk about that a little bit more, and then pharmacotherapy. Here's the Canadian medications that we have, but put in any country's pharmacotherapy options that work within the brain and neurochemistry to help to dampen down those neurochemical systems. And then bariatric surgery, which again has an aspect of going to the brain and telling the brain positive messages. So here is where we had our initial bias. The previous guidelines stated that the optimal dietary plan you should work to reduce your calorie intake by 500 to 1,000 kilocalories per day. We do not have any evidence that somebody can actually write down their calories and actually sustain a 500 to 1,000 kilocalorie deficit every day. We have actually the evidence against it, that people cannot do that. What we do have evidence for is if you have high blood pressure, then the DASH diet would be appropriate. If you have coronary artery disease, the Mediterranean diet works. That's what we have actual evidence for. So let's use the evidence that we have and move away from this idea that you need to write down a reduction in calories. You need to have healthy, appropriate medical nutrition therapy, and we'll leave the reduction in calories, which is what's needed for weight change, to the three pillars. So here again, diet versus medical nutrition therapy. So we've done our best in the guidelines to take out the word diet and primarily use, because it has a negative connotation. Dietary is a little bit better, but diet usually means you're doing this by itself, you're decreasing calories, and the likelihood is that you're going to fail. So we're setting people up for failure on a regular basis. Whereas if we start them with medical nutrition therapy, we're not setting them up for failure. We're setting them up for success with proven evidence. And if we look at the cognitive behavioral therapy, here I have a picture of Dr. Sandy Van. She's a physician that works using CBT for weight management. So CBT and psychological interventions isn't just simply the accountability, showing up to a clinic on a regular basis or somebody giving you a phone call, but it's actual strategies that you have that need to be learned. They need to be taught, and someone needs to have the training in it. So things like coping mechanisms. So if you recognize that you have poor coping mechanisms from a day at work and you've had a lot of stress, and if you are an alcoholic, let's say, what would you use as your soothing aspect? Alcohol. But of course, the majority of people oftentimes will use food as their soothing mechanism to deal with coping. How can you, so now that you're cognizant that you're using food as a coping strategy, can you change the behavior, and how do we do that? That's what cognitive behavioral therapy is. It's a medical intervention, and it's not to be lumped into diet and exercise. It's to sustain diet and exercise, and it's a specific therapy. Also, food addiction therapy. So food addiction therapy is also an important aspect because it, again, works in the brain. And when we think of food addiction, people go, well, you know what, how can you be addicted to food? Food is actually everywhere. Well, I'll tell you what we're not addicted to. We're not addicted to broccoli. That's food. But many people are addicted. The people who have addiction are addicted to chemically engineered foods, and they're like drugs. And therefore, if you have an addiction to this type of drugs, which is a percentage of the people living with elevated weight, you may need specific food addiction program aspects. And that is, again, using the cognitive lobe and getting away from this idea of diet as being the only thing that treats elevated weight. So in Canada, the 3 pharmacotherapy options are here, and this is one of the pillars, as I stated. And we are getting more and more of them that will primarily work within the brain neurochemistry to be able to help to work properly with our understanding of the biological processes. So the pharmacotherapy that has been developed, and we know that in many fields, pharmacotherapy has significantly changed the way that disease state is currently looked at or currently treated. So in the field of high blood pressure, coronary artery disease, diabetes, breast cancer, pharmacotherapy gives that added component to be able to help the patient do well. So that's what this does. The 1-year trials looking at how many patients got to greater than 5% weight loss, greater than 10% weight loss, but even more so, affected their health parameters. Did they improve their pre-diabetes, their type 2 diabetes, their NASH, polycystic ovarian syndrome? So those are things that we want to look at, and we know that these medications can actually do that. So we developed a pragmatic algorithm to look at the pharmacotherapy options. Again, the BMI categories were here, and I believe that this is a bias aspect. I don't like the fact that BMI categories are what was used, but the FDA and the regulatory bodies and the EMA use that, and I think we'll go away from that in an eventuality. So first we look at stopping or changing medications if weight gain, if they're causing weight gain, if that's possible. Then looking at the comorbid statuses. Again, this goes away from size and goes more so to what are the health impairments the person has. If they have the number of the ones listed on that side, come from diabetes all the way to polycystic ovarian syndrome, we know that the GLP-1 analogs have been a first-line treatment here. If cravings and depression and smoking are a challenge, then the naltrexone bupropion, a medication we have in Canada, has some treatment options here. So that would be first line. So we have some ideas here in Canada about some first line treatments that you'd look at and some second line. Again, there's multiple other components that would make the choice for the person. And then looking at what how you would assess things in a number of months to see whether it's working. It's not looking primarily at weight. It's looking at, did it change the health parameters that you were interested in? And if it does, then it's a successful medication. If it did somewhat but not as well, you can add in another medication or you can switch. So the idea is that just like in diabetes care, we start with metformin, we add things on top. It's also here. And my final slide is talking about these bookends. I said that the first bookend is the bias chapter and the end is the Indigenous chapter. In Canada, the people that suffer the most from obesity are the Indigenous group. And in Canada, the people that get the worst care for obesity is the Indigenous group. And so here are some of the components that they talked about in our chapter. These are actual patients speaking in a qualitative manner. Addictions and obesity are fused together because of years of abuse. Some people suppress these memories with eating. And another statement here where an Indigenous patient was pleased that her doctor wanted her to come back on a regular basis. This is a good doctor, she actually stated, because we know access to care is one of the big challenges as to why the Indigenous population and racialized group don't get appropriate care. And this last slide here looked at a study that we did in Canada showing that people of color actually face worse treatment as well. So we looked specifically at ethnicity, and what we found was that white women lose more weight than women of color in Canada, a first world country. And what we found out is after we adjusted for the number of visits, there was no difference in weight loss success. So what this meant was that maybe women from an immigrant population or an Indigenous population couldn't get to the clinic as often. They had challenges and difficulties getting to the clinic. So we need to be better at helping them to access care. And potentially in our world of virtual medicine, we may be able to actually do that, to take advantage of those aspects. So in summary, what's different and what did we do here in these guidelines? We addressed the idea of bias. We stated that we all have bias, and these guidelines end up calling this out. Let's try our best not to act on these biases by following appropriate guidances. Medical nutrition therapy is a replacement for diet, and I'd advise everybody to look at a direction like this, getting rid of this concept always of just calories. Psychological intervention is not lifestyle management, it's a medical intervention. And we talked about cognitive behavioral therapy being one of those. And that racialized groups should be recognized. And there's certainly a number of challenges there, but we can do better. So thank you very much for your time, and I will stop sharing.